look at basic intro to second level pharmacology for veterinary technician students. I know pharmacology is not the most loved topic. I know it's complicated and it's based a lot in physiology. So bear with me. I'll try to make it as interesting as possible. One good thing that's a benefit to pharmacology is that there are also a ton of YouTube videos that have really intellectual, really educated people who are able to explain concepts. So if I can't explain it for you in this method, it might be worthwhile just Googling some YouTube videos. Okie dokie, so let's get started. Plans for today, we'll review course outline and syllabus. The textbook, I highly recommend it for the course. It's really good just to have a reference material like that. We'll do a little bit of a review, and then we'll start talking about analgesics today, and then we'll get into tranquilizers and sedatives, as well as anesthetics. So review of pharmacology. Overall, what is the RVT's role within pharmacology? I'm hoping that everybody learned this previously. Our role is identification of normal and abnormal drug reactions, monitoring patient status during drug therapy, so that could be during anesthetics or diabetes protocols, identifying patient response to drug therapy, implementing a reversal plan for patient drug reactions. So note that we are not prescribing medications, we're not in charge of that, but we need to be able to recognize what's normal and abnormal. So if we give a medication, if an animal has an adverse reaction, we need to contact the doctor immediately to assist in that and facilitate recovery. Likewise, we need to know our math and we need to know what are normal and abnormal doses of common medications. That being said, we've all worked with different people in our lives. There are some people who are better at math than others. For some, math comes very naturally to them. General rules. All drugs are poisons, so we are giving specific amounts of a poison to create a specific effect. That being said, no drug is a silver bullet, so the same dose that worked for the golden retriever may not work for the second golden retriever. All doses are guesses. They are guesstimates, they're best guesses based on clinical data and studies, but they are in the end guesses, which goes back to no drug is a silver bullet. We don't have guarantees. And complacency kills. So this could be applied to so many situations in veterinary medicine. Complacency when it comes to the doctors choosing the same medications over and over, treating every patient as the same patient, that can be complacency, that can kill a patient. And then with us, if we're not double checking, if we're not being up to date on new medications that come out, if we're not aware of side effects, of contraindications, etc. for drugs, then of course we can end up with a dead patient. And that's not our goal. Some general terminology. We've got generic name versus trade name of drugs. We've got generic equivalents, VPCR, over-the-counter versus legend drugs, and of course controlled substances. So generic name versus trade name. Generic name is essentially the drug itself. So it's not the molecular, the chemical compound of the drug. There's that name as well. But it's the generic name that's given to a drug once those specific chemicals have been combined. And then, of course, a trade name is once a company owns that drug or owns a patent to the drug or they're producing the drug, then they can put whatever name they want on it. So an example of that would be meloxicam is the generic name and Metacam is the trade name. Other examples, we've got Butorphanol is the generic name, that's the drug name, and then Torbugesic is the trade name. Ketamine is the generic name, and Vetilar is the trade name. Generic equivalents. So this is when there are essentially companies like Apotex or Siva that just sell the drug as is. So it's not rebranded under a secondary company. So Apotex, I believe they have apomaloxicam, which is the drug that Metacam is, and Metacam itself is owned by Boehringer Ingelheim. Well, they lost their patent a couple years ago, so now all these generic companies can go ahead and produce meloxicam. Depending on the drug, but typically they go through more or less the same amount of testing. It's compound drugs, which we can talk about at another time, that have typically a little bit less testing. But generic drugs often are interchangeable with the trade name drugs. VPCR, veterinary patient-client relationship. In Ontario, we always have to have a VPCR, so a relationship with the client before we can administer a medication to their pet. So the doctor has to know who the client is and they have to have seen the patient. So this is why clients, when they call us and say, hey there, I just need some insulin because I think I have a diabetic cat, we definitely can't go ahead and dispense that if the doctor has never seen the patient or the client. There are implications, of course, legal implications if we do that. And of course, there's potential health implications if the doctor administers or dispenses medication without ever seeing the pet. I'm sure you can let your mind wander on that one. And then there are over-the-counter versus legend drugs. We're going to focus on legend drugs, so those are the ones that you need a prescription for. And of course, controlled drugs we'll talk a lot about today because we're going to be talking about opioids, which are controlled drugs are governed by the Government of Canada. Typically, they have a high propensity for addiction and as well as other effects like sedation, euphoria, etc., etc. So the College of Veterinarians of Ontario, they regulate controlled drugs in Ontario for veterinary clinics, and then of course we submit or they submit data to the Government of Ontario. So what information has to be on a drug label? This is just a bit of review. Clinic information and doctor name has to be on it. So typically we're talking the clinic name, the address, the phone number so that they can contact. The client name, and typically their ID number, but client name, patient name, the instructions for the medication and the strength of the medication, and the expiry for the medication, as well as the total number. Okay, all of that is included on a drug label. You've probably forgotten that because it comes so second nature to us to include all of that. And then, as I mentioned before, who oversees controlled drug log? That is the College of Veterinarians of Ontario for us directly to the vets. And then the bigger picture is the Government of Canada. And then which information has to be kept in a drug log, a controlled drug log. I'll show you at the end of this lecture. We'll go through controlled drug logs and I'll show you typically what's kept within that. And then we'll do some terminology trivia in class this week as well. So today we're going to start the big chat about nervous system drugs. So these are drugs that work with the nervous system. They work with nerves, with receptors, with the cells that are involved in overall conducting impulses to the spinal cord and to the nerves. So we're talking within this analgesics, tranquilizers and sedatives, anesthetics, and CSS stimulants. So far in this lecture, we're going to cover analgesics. All right, a little bit of terminology. We're going to use some terms as we chat throughout the next hour or so. Nociceptor, I'll mention probably quite soon. That is another word for a pain receptor. So nociceptor is a pain receptor. Opioids we'll talk about in detail. They are synthetic compounds that essentially replicate or synthesize the effects of opiate drugs. And opiates are direct derivatives of the poppy. So opiates create euphoria, addiction, respiratory depression, etc. Opioids are the ones that are man-made, so they're chemically synthesized to act the same as opiates. Neurolept analgesic is a form of analgesia and essentially sedation, where we're mixing analgesic drugs with sedatives or tranquilizers to get a combined effect. An agonist is a drug with a good affinity for the receptor, for that specific receptor, and an ability to produce an intrinsic effect on the receptor or on the cell. An antagonist has good affinity for the receptor, but little or no intrinsic effect on that cell. And then we have partial agonists / antagonists. Essentially, they have good affinity for the receptor, but partial intrinsic effect on the cell. And don't worry, we'll talk about all of those in much more detail as we carry on. So right now we're going to talk about the pain pathway. Pain pathway is so important for RVTs in this world, in Ontario for sure, but in this world in general. Because one of our newer roles over the years is to really advocate for patient pain management. And like everything with veterinary medicine, we follow closely the human medicine side. So when they realize something in human medicine, then we tend to get it down the pipes about 5 to 10 years later. So what they're discovering now, We have a huge ability to prevent pain and pain wind-up in patients when they are undergoing a painful procedure or when they have a painful disease process occurring. So with that, in order to be able to sort of accommodate pain or prevent pain or stop pain from progressing, we need to know about the pain pathway. So this goes all the way back, hopefully, to anatomy and physiology. And we're going to discuss the pain pathway. So this is back to our sensory anatomy. So step one of the pain pathway is the actual stimulus. So this is now the body has acknowledged, not really acknowledged, but the body has recognized that there's a painful stimulus. So somebody stepped on this dog's toe really, really hard. The body then translates the physical stimulus into excitation or depolarization of pain receptors, so nociceptors, and that specifically is called transduction. So it's taking the painful stimulus and it's entered into the body and it's sort of flipping the switch for those pain receptors. So those pain receptors are getting turned on, they're depolarizing. Step two happens up in the peripheral nerve bundles. So this is conduction of pain impulses from peripheral nerve bundles to the spinal cord, and that is called transmission. So it's transmitting the signals from the area of pain and it's heading up toward the spinal cord. The third step is transmission of sensory depolarization wave, so that wave of pain, essentially. And if you picture it, it's like when people do the wave at a stadium. Every time somebody stands up, that essentially is a pain receptor being turned on or depolarizing. So it's transmission of the sensory depolarization wave, i.e., the cells are getting turned on, they're getting depolarized, and pain signals are getting sent out from the spinal cord to the brain to perceive the pain. Okay, so that is called modulation. So now the body is fully encompassed in these pain receptors and it's now traveling, it's gone from the toe, it's gone up to the spinal cord, and now during modulation, it's getting sent directly up into the brain. Step four is when the brain actually perceives the pain. So that is the brain's ability to perceive the level of pain, and that's really scary for the patient. So if we look at this, essentially right now, the pain pathway is so important to us because specialists have identified that blocking pain at multiple points is much more effective than trying to treat the pain. It's also much more effective than just using analgesic drugs or just using local anesthesia. So essentially, for prevention, during the transduction phase, local anesthetic can be applied to the area prior to inducing pain. So before that surgery starts, we can actually use local anesthetic on the spay incision site or in the testicles, depending on the surgery. So before inducing pain, and that will block the pain pathway and the nociceptor will avoid depolarizing. Okay, so that's one way during transduction we can apply a local anesthetic to prevent that start of the depolarization wave. During transmission, you can use local anesthetic to block a peripheral nerve bundle to prevent the transmission of pain pathway to the spinal cord. So right here, if we add local anesthetic to this sort of like this highway, so we put a roadblock here, the cars, i.e. the pain, kind of got around it. It's working its way up the peripheral nerves. If we put another roadblock up here, i.e. a local anesthetic, we can potentially prevent a lot of those pain receptors from being turned on before they reach the spinal cord. This method is often used during cattle standing anesthesia, and they'll block a large area of skin closer to the spinal cord than the surgery itself, therefore offering an opportunity to block the transmission to the spinal cord. So it's kind of cool, even though surgery might be happening on the foot, if we block these peripheral nerve bundles up in the leg, it's still preventing another, or it's adding another roadblock to prevent pain perception in the end, so prevent that pain from waving forward. During modulation, a lot of analgesic drugs will act by increasing the degree of inhibition, so i.e. the degree of preventing those receptors from depolarizing, those cells, those pain receptors from depolarizing, or dampening the pain signals that actually reach the conscious brain. So providing some nice analgesic drugs can actually dilute or filter the amount of nociceptors that will get by depolarized, and eventually prevent the amount of perception the brain receives. So all of that is so, so important in preventing wind-up. So wind-up is this thing that they finally acknowledged years ago, whereby we could have an animal under anesthetic. So we've taken away their reflexes, we've taken away their ability to physically react to pain. And what often happens, before we would give pre-anesthetic analgesics, we would just assume that that animal had no pain because they're under anesthetic. But what was actually happening is that the transduction, transmission, and modulation was still occurring. And when they woke up from anesthetic, their perception was insane. So their amount of pain that they were perceiving was like blowing through the roof, totally uncontrollable pain. So we can prevent that by creating all these little roadblocks to the pain pathway throughout our anesthetic process and our analgesic process. Pain is way easier to prevent than it is to treat. It's really hard to get animals down on the pain scale, whereas if we just prevent it and stop them from peaking at like a 10 out of 10 for pain, it's a lot easier to do than actually treat it in the end. I don't know why I redid that little circle. Okay. So analgesics, we'll talk about, they prevent pain wind-up. So they create a balanced anesthesia and pain management. And we'll see there's lots of different analgesic drugs. There are also anti-inflammatories that we use a lot in order to prevent the pain pathway as well. We'll talk about anti-inflammatories later on. We're right now just going to focus on analgesics and the different types of analgesics available. So if we sort of encourage our veterinarians as we work with them to use analgesic medications throughout the potentially painful process, then us as RVTs are able to really create that balanced analgesic and balanced anesthesia process for that animal. And then we're not trying to fight a dog with analgesics after the fact, trying to bring their pain down when they're at like a 10 out of 10. All right, analgesics. So we're going to talk about opioids. Poppies are a plant, of course, that grows, as you know, and poppy seeds, derivative of poppy seeds, are opiates. And opiates are the chemical drugs derived from poppy seeds, such as heroin, essentially. Chemically synthetic opiates, so ones that we've created to synthesize the effects of opiates, those are called opioids. And they bind to opioid receptors. Examples, of course, are oxycodone, butorphanol to a point, and we'll talk about some others like hydromorphone. They are narcotics, so not all narcotics are opioids, but all opioids are narcotics. And narcotics refers to a broad class of drugs that create this narcosis or this stuporous state. The use of these drugs is to reduce pain. That's what they should be used for. We often use them in combination with anesthesia to reduce the amount of anesthetic needed. And originally, oddly, who knew, but opioids were used to treat diarrhea. So during those days of cholera and dysentery, because opioids have an effect where they can actually create constipation, they can increase the muscle sphincter tone, they can create constipation with prolonged use. Unfortunately, opioids are extremely addictive, so they are a controlled drug. We have to be very careful about our stockpile or our stock counting of opioids, because if any go missing, we technically have to alert the police, because taken in high doses, they are actually taken in fairly low doses. They can be deadly. I should correct that. So a little bit more about opioids. Opioids bond with specific receptors, which we'll talk about. They also, so that's throughout the body, and then they also bond with specific receptors in the gut, and that's what decreases the gastric motility and increases the rectal tone. So that's the reason that they can cause constipation. However, when we give them initially, they can cause spasmogenic action of the intestine, which causes immediate diarrhea. So we'll talk about the benefits and drawbacks to opioids. Maybe I'll even come back to that portion. All right, how they work. So they are a receptor-based drug. So they enter into the body, and then on the cells, we have these little receptors that are little proteins that sit sort of in that fluid mosaic between the outer layer of the cell membrane, so the plasma membrane, and the inner layer of the plasma membrane. So these receptors kind of just hover on the plasma membrane of the cell, and they only accept certain drugs into them. So they're kind of like a specific puzzle piece, and you need to have that other piece that fits perfectly in order for those receptors to acknowledge them. The receptors that we'll talk about with opioids are the mu receptor, kappa receptor, and delta. There's also a sigma receptor. Was it sigma? I'll have to double check it, but I'm pretty sure it was sigma receptor too. We tend not to talk about delta and sigma much at all. We really focus on mu receptors and kappa receptors when it comes to opioids. Mu receptors create the most analgesics, so receptors or opioids that are consistent with mu receptors or are mu receptor based. They're really known for their amazing level of analgesic. And likewise with kappa, they also play into the analgesic properties. Kappa, so drugs that have kappa susceptible receptors as well, they also are known for their sedation. So opioids have presynaptic and postsynaptic effects. Presynaptic, they prevent the release of the neurotransmission. And postsynaptic, they kind of create that inhibitory effect, so to prevent more of those pain receptors from depolarizing. A little bit of review. So going back to physiology, another favorite among students. So going back, I'll just show you here. This is the picture from your current textbook. What this is displaying in here is the inside of a cell. This is outside of a cell, and this is the plasma membrane. Okay, with the hydrophilic and hydrophobic ends. So the receptors technically kind of sit within that plasma membrane because then they connect to the other side and they allow that drug in. So here's a good example. Chemical signaling. So this is the binding sites that fit a specific shape. Okay, so this is very specifically, that's that protein that sits within the plasma layer. It accepts only that specific shape, which is the opioid. So this is the opioid. This is the opioid receptor, and then it allows it to have an intrinsic effect on the cell. So it allows the effects of the opioid to then react to the inside of the cell. How they work, we have an agonist and antagonist effect. There's also partial agonist and partial antagonist. Same thing. Many opioids are mixed, agonist, antagonist, and they combine with multiple types. Oh my gosh, I can't say it. Of opioid receptors. So an agonist is a drug with good affinity for the receptor, i.e. it fits with the receptor. It's like that missing puzzle piece. It fits the receptor perfectly, and the ability to produce an intrinsic effect on the cell. So that means that they are the missing puzzle piece, they fit, and then when they fit, the cell takes in all that benefit and drawback of the opioid, and they actually have an effect on the cell. An antagonist is a drug with good affinity, so it fits, it's that missing puzzle piece, but little or no intrinsic effect. So it might just fit the opioid receptor and then do nothing, which we'll talk about later because they're really important. Then we have partial agonist antagonists when two drugs bind with a receptor and cause intrinsic effect. The drug that causes a lesser effect is the partial agonist antagonist. And what they can do is actually bump out a full agonist. They can bump out their effects to create their own limited effects. So that's essentially the next one, which is a competitive antagonist, when the effects of one drug stop the effects of another drug when connected to the same receptors. And don't worry, we'll go through examples of each of these. Okay, so how they work, we've got this agonist and antagonist, also partial agonist, antagonist, etc. So an example, so we've got an agonist, a drug with a good affinity for the receptor, so it's the missing puzzle piece, and it has the ability to produce intrinsic effects on the cell. So it fits the missing puzzle piece, and it also works really well on that cell, really important. An example of this one is morphine. So morphine bonds really well to mu receptors, and it has really strong effects on the cells. So we'll talk about morphine a lot. Every other opioid is measured against morphine. So it's either stronger than morphine, less strong, or weaker than morphine, etc. So an antagonist is a drug with good affinity but little or no intrinsic effect. So again, it's the missing puzzle piece. It's going to connect really well to that receptor, but then when it connects, nothing happens. An example of this one is naloxone. So naloxone, we'll go through, it's a medication that we give to essentially reverse the effects of opioids because it binds with the same receptors that opioids bind with, but causes no effect on the cell. It can actually take up a ton of opioid receptors that are available, plug itself in, and then have no effect. So instead of that morphine continuously connecting to the receptors and creating this huge effect, instead naloxone is now taking up those receptors and nulling the effect of the opioid itself. And we'll talk about naloxone again. And then we have partial agonist-antagonist. When two drugs bind with a receptor and cause intrinsic effect, the drug that causes the lesser effect is the partial agonist or antagonist. Competitive antagonist, is when the effects, okay, I already went through that. So an example of a partial antagonist / partial agonist, same thing, would be butorphanol. So essentially, it binds with the same receptors as morphine, but it's going to have less of an effect. So then we could actually use butorphanol to reduce some of the effects of a higher opioid such as morphine. Okay, so here's a little, not dumbed down version, but just a little pictorial version of what the heck I'm talking about, because it is a lot to wrap your head around. All right, so we've got 3 opioid receptors. So these are sitting on the cells. They're protein-based. They sit in that plasma membrane of animal cells. So here we go. We've got hydromorphine. This hydromorphine molecule, it fits perfectly with the opioid receptor, and it has a high intrinsic value. So that means that it has a high intrinsic effect on the cell. So this is a pure agonist. Okay, so it fits perfectly, and it has a intrinsic effect on the cell. 4 to 6 hours, high level pain relief, but it will cause respiratory depression as well. So that is hydromorphone. And then we have this opioid receptor, and we have amoxicillin molecules floating around. So we've got antibiotic molecules floating around. Well, they don't even fit together, so that's not going to work. Nothing's going to happen. So no effect. The drug doesn't even match the receptor shape. Not happening. And then we have this guy, butorphanol, who's a partial agonist-antagonist. It fits the opioid receptor really well, but it has less intrinsic effect than hydromorphone. So hydromorphone, you're going to get tons of sort of longer lasting pain relief. You're going to get respiratory depression. The animal might even be a little bit sedate, not much from hydromorphone. Butorphanol is kind of crappy. It only lasts for 30 to 60 minutes for pain relief, causes not much respiratory depression. But what's happening is now that you've given hydromorphone and butorphanol has taken up some of the opioid receptor spaces. It's less effective than hydro, so essentially what's happening now is it's actually taking away the effects of hydro because it's replacing itself, or it's taking up the spaces that the hydromorphone should have taken up. So that is, we've got a totally 100% mu agonist, so working on the mu receptors. We have amoxicillin, which isn't even going to combine with the receptor, so that's just to show you the difference in shape. And then we have this guy, which is a partial agonist-antagonist, which fits the receptors but has a lesser effect. So it's actually, in a way, reversing the effects of the hydromorphone. It's being a pain in the butt is what it's being. So it's stealing receptors. So here are some examples. We've got mu agonists. Good examples are morphine, hydromorphone, oxymorphone, and fentanyl. We'll mostly talk about morphine, hydromorphone, and fentanyl quite a bit. The effect on the body is analgesia, profound analgesia, and a little bit of sedation. If they work on the kappa receptor, they get more sedation. And the negative effects, oftentimes we get immediate vomiting, which we'll talk about in a little while. Respiratory depression, we can get dysphoria. So if we give too much of the drug to the animal, instead of euphoria, like a good feeling, they get dysphoria, where essentially they're hallucinating. They can be anorexic, so not eating. They can hold their urine because they get urinary retention, initial diarrhea, potentially, and then long-term constipation. So long-term opioid use can cause constipation. So then we have, we talked about before, the partial antagonists or partial agonists, same thing, Butorphanol. So we'll just add them in mentally. And then we have a mu antagonist, and that's naloxone. So that reverses the symptoms associated with mu agonists. So essentially remember that the mu antagonist, it connects with that mu receptor, but it actually causes no intrinsic effect on the cell. So it's taking up that receptor place and it's essentially kind of blocking the effects because it's just giving no effect. So it's taking up all the spaces that the agonist would otherwise take up, but it's providing no effect, which can actually reduce the effects of hydromorphone and other opioids. Interesting fact, mu agonists depress the respiratory system. They also suppress the cough mechanism in animals. So, that being said, if we give too much of an opioid, of a pure mu receptor opioid, then of course we can cause death because their respiratory system gets so depressed it just stops working. But also, kind of cool, hydrocodone is a cough medicine that we give to dogs typically that have kennel cough and have that really severe cough and they just can't seem to stop coughing. That is an opioid. So we're giving them an opioid to suppress the cough. Now, downfall too with the cough suppression, if we think about it when we have an animal sedated, so for a minor procedure, they're sedated, we've used an opioid as well as a tranquilizer or sedative. We have to remember that animals with opioids on board won't cough. So if an animal is really flat out sedated and they have eaten in the last few hours, and they vomit or they regurge, if that regurge goes back into their lungs, so it goes back down the trachea, they won't cough it out. So we have to keep that in mind because it becomes a dangerous thing. That's why we should always intubate animals who are under anesthetic, because these opioids suppress the cough reflex. Really important for us as RVTs to remember that. All right, so we're going to talk specifically about some opioids that you will come into contact in your lifetime with. So we have trade names. We've got morphine, trade names. Essentially, it's just called morphine, so that's the generic name. I should scratch that out. You should scratch that out. There aren't a lot of trade names for morphine, so typically it's referred to by its generic name, which is morphine. Its mode of action, it's a mu agonist, and it has some kappa agonist activity. So that means as a mu agonist, we're going to see analgesia, and we're going to see respiratory depression, etc., etc. But because it's a kappa agonist as well, we're going to see a little bit of sedation with morphine. It's important to note that the efficacy of morphine alone for surgical pain is not ideal. Opioids are better at blocking dull, aching pain than sharp pain associated with surgery. So positive effects, we have excellent for visceral and superficial pain receptors. So that's kind of that dull pain, not the specific sharp surgical pain. And it can be used as an epidural drug as well to block those pain receptors or inhibit the pain receptors from depolarizing. Low doses can cause euphoria, so that's a positive effect. The animal will feel very good with morphine. Side effects, so sort of negative side effects. If it goes IM or sub-Q, the animal, most often the dog, will salivate. Cats often salivate too. And dogs in particular almost always vomit. Now, with the vomiting, if we give it when an animal is actually intensely painful, they won't vomit. It's like it blocks that entrance into that pathway and they just tend not to vomit. Higher doses can cause dysphoria, so that's that less comfortable form of euphoria where they go one step too far and they start to hallucinate. We can get meiosis and mydriasis. So meiosis happens in dogs, rabbits, and rats, and that, of course, is the pupil constricting. And then mydriasis happens in cats and horses. Another documented effect is IV. If we give it IV, we worry, or some people worry a little bit about a histamine release. So, on a cellular level, release of histamines from mast cells. It's debatable the full effect it has on the body, whether or not it produces clinical vasodilation because of that histamine release and reduced arterial blood pressure. It can be more profound when giving the drugs that decrease cardiac output. So we have to watch what drugs they're giving it with, but some people initially get a little bit worried about vasodilation, so because of histamine release. And with that, people tend not to use it with animals who have acute head trauma because they're already at release or at risk of vasodilation. We don't want to increase that with histamine release. Also, with the histamine release, if a dog or a cat has known they definitely have mast cell tumors, we often tend to give it IM or sub-Q rather than IV because of that potential for histamine release. In cats, too, they've documented slight hyperthermia after morphine has been given, although it tends not to be profound hyperthermia, so we tend not to worry about it too much. Administration of morphine, we've got sub-Q, IM, IV. We can also do it as an MRI, as a CRI, which continuous rate of infusion, and IV, we tend to get less vomiting. So a little bit of interesting fact here. Apomorphine is a derivative of morphine, and it's used to stimulate the dopamine receptors to produce emesis or emesis. So essentially, vomiting occurs, which vomiting is emesis or emesis, occurs when opioids reach the chemoreceptor trigger zone, so the CTZ, and activate the dopamine receptors, which trigger the emetic center receptors before they pass through the blood-brain barrier. Say that 10 times fast. It's kind of cool. When given at higher doses or IV, these little receptors, they reach the blood-brain barrier first, and they shut off the emetic center receptors. So vomiting typically occurs when opioids reach the chemoreceptor trigger zone and activate the dopamine receptors, which trigger the emetic center receptors before they pass through the blood-brain barrier, okay, because they get sort of pushed out of the blood-brain barrier. So we tend to use this derivative of morphine to create emesis in dogs and cats. Now, cats, it tends to be less effective in because they have less dopamine receptors and therefore are less likely to produce emesis. So apomorphine we often give to dogs. Most often it's dogs. We do try it in cats if it's a need basis, so if the benefits outweigh the risks. And dogs, we're often giving it to them if they've ingested a toxin. So dogs that recently have ingested rat poison or mouse poison, or if they've ingested a very small foreign body that has the likelihood of coming back up through the esophagus, then if we can get them into the clinic fast enough, we'll give them typically IV apomorphine, goes into the vein, and it produces emesis within like 3 minutes. They'll start vomiting. You also can give it sub-Q, takes a little bit longer. And then the other way to give it is transmucosal. So they come in these little tablets. I'm not a huge fan of them. You put them in the mucous membrane, so in the conjunctiva between their eyeball and their eyelid, and it gets absorbed through their mucous membranes there. Downfall of that one when it's transmucosal in their eye, in their conjunctiva, is the eyeball itself gets really irritated. And they're a little bit more difficult to get out because the goal is to put the little tablet in their eye conjunctiva and then take it out once emesis is complete. It's irritating for the eye. I'm not a big fan. I love it IV. It's pretty amazing. So the same sort of principles can be applied to overall opioids because we know that they also can produce emesis. So when we give opioids, so like hydromorphone or morphine, at higher doses or IV, they reach the blood-brain barrier first, and they actually shut off the emetic center receptors. So if we give opioids sub-Q or IM, or if we give them in lower doses, it gives the body more chance to then send them to the dopamine receptors and then, of course, to the emetic center to create vomiting. So it's interesting. So you'll see vomiting in your patients if we give lower doses in non-painful patients, so typically pre-surgical patients, or if we give it sub-Q or IV or IM, if we give those opioids sub-Q or IM, then you'll tend to see emesis more often. That's a happy little dog barfing out some rainbows, which I wish is what barf looked like, and it does not. All right, so going back to some examples of opioids, hydromorphone is a really common opioid that we use in vet medicine right now. Its trade names are often Dilaudid, is the one that we typically use. Do have caution, really important to know, there are different strengths of hydromorphone. There's a 2 milligram per mil strength and a 10 milligram per mil strength. The other company that we get it from is Sandoz, and I think it's the Sandoz hydromorphone that we tend to get the 2 strengths in. Bottles look almost identical, typically just different color on their labels. So really important because you do not want to overdose an animal on hydromorphone, nor do you want to underdose them if they need it for pain. Mode of action, it's a pure mu agonist. Positive effects, we've got the analgesic properties at a lower dose than morphine. So this is a much stronger drug than morphine. Less emesis stimulation than with morphine. Less histamine release when IV. And it has longer duration than morphine. So that's the key with this one. Longer duration, 4 to 6 hours. Side effects, it can cause more significant hyperthermia in cats. Although that hyperthermia typically lasts a short duration of time post-surgically. And I've seen that quite often in cats, typically lasts about a half an hour. So we have to be very cautious within that first half hour after surgery. IM or sub-Q, they do tend to salivate and vomit, dogs more specifically, and in higher doses can cause dysphoria. Meiosis and mydriasis definitely can occur as well. Administration, we give it sub-Q, IM, IV, and of course with IV we get less emesis. Oh no! All right, then we have fentanyl, which again is a pure mu agonist, often called Duragesic, and we have Duragesic patches, etc. for fentanyl. Positive effects, we've got analgesic properties at a lower dose than morphine because everything's measured against morphine. So again, this is stronger than morphine. The side effects of this one, it's challenging because there's short duration of effect, 30 minutes to 2 hours. Higher doses again can cause dysphoria, meiosis or mydriasis occurs, and there's challenges with administration due to short duration. So fentanyl, we don't often see fentanyl be given just as a one-shot deal. So IV, here's your fentanyl, there you go, there's your pain medication. Typically we see fentanyl given in a constant rate of infusion, so a CRI drip, most often in hospitals to have that constant control of pain, so pain management. And then likewise, we also see fentanyl given as a patch. We can give it IV, always keep that in mind, but we often see it sent home as a transdermal patch. And this is what it looks like here. So transdermal patches, they are patches that have a protective plastic layer on the outside, and then on the inside you peel off the little plastic layer and it gets stuck directly to the skin. They are sticky and they have this gel impregnated with fentanyl. So based on the surface area of the animal, that's how we calculate the dosages of the fentanyl patches. It has to be placed on a shaved and clean surface. And if an animal has really greasy, overproductive sebum type skin, we really have to clean that area and dry it quite well. Never ever cut the fentanyl patch because it's impregnated with that gel that contains the fentanyl. If we cut the patch, that gel can leak out. So there's a couple really big implications with that. When it leaks out, the alcohol that's based in the gel that sort of maintains it there can start to evaporate. So our actual fentanyl dosages will become weaker for the animal. So implication number one is that the animal won't get the analgesic that they need. Implication number two is, of course, if that gel is leaking out, somebody could touch it and then it's transdermal and they could potentially be taking fentanyl without knowing. So really important. The main thing is that it changes the dosage for the dog. There's variability in absorption for animals, typically 12 to 24 hours before the patch is actually effective on animals as well. So oftentimes we're using this with some major surgeries like a TPLO or back surgery, maybe not, yeah, back surgery, other leg surgeries quite often. And typically we'll put it on the animal the day before surgery or use an injectable during surgery, after surgery for a balanced analgesia because it takes so long to kick in. The patches are good for 24 to 72 hours in the dog and up to 4 days in the cat. The downside, of course, because it's variable, we're never quite sure how much fentanyl is making its way through the skin into the animal's circulation. So you have to be very cautious to educate owners on how to monitor for signs of pain in the animal. The exact location that it should be placed on is identified in the packaging, and quite often the packaging indicates that it should go over the shoulder. And that's based on their studies to ensure the rate of absorption by the manufacturer. Most patches, I'll tell you, are not placed over the shoulder because of movement of the shoulder during locomotion. Quite often they're placed over the thorax, the abdomen, and of course in the sort of like that epidural space of the dorsum. So if we go back to the fact that there's the dosing for fentanyl is based on surface area, we might not have a fentanyl patch that's specifically adequate for that animal. So it might be too big for the animal, or it might be too small for the animal. If it's too small for the animal, then we can use like 1.5 patches. If it's too big for the animal, we can use half a patch. And again, instead of cutting it, what we would do is leave the protective film on that half of the patch, or however much it is, like the quarter of the patch. Leave the protective film on the sticky side so that we're leaving the fentanyl patch intact and only a portion of it's exposed to the skin. Fentanyl is a huge topic right now. So as you guys know, it has really big street value right now. It's extremely potent. It's one of the most potent opioids available to us. So we have to be really cautious about this. So we have a patch out, patch in system. So of course, an animal that goes home with a patch, some clinics even put deposits on the patch until the owner brings the patch back to confirm that the patch has been returned to the clinic. Because if an owner sticks the patch on themselves, if they have any sort of addiction, opioid addiction issues, we just have to be so careful with that because of course they could be getting opioids and then you never know, they could overdose on opioids, and that's on us in many ways. So what if the patch falls off at home? This is a huge concern. What if the dog or cat still seems painful? What if a kid takes the patch? What if the dog eats the patch? And the list goes on. So we have to have a huge education program when we're sending dogs and cats home with opioid patches, fentanyl patches in particular. They can be really effective and they can be really helpful for the post-surgical patient or the very painful patient, but we have to be very cautious about what happens to that opioid or that fentanyl patch. If it falls off, that animal needs to come back in, like ASAP, to get that patch reapplied. If the animal still seems painful, we need to check that patient out. We need to make sure that the patch is in fact working, we've applied it appropriately. Maybe they need supplementary medication. If a kid takes the patch, it's really scary because they might just pick at it, take it off, and then as soon as they have that sticky side on their skin, they are getting fentanyl transdermally. Really scary. If the dog eats the patch, then of course they can overdose on fentanyl, etc., etc. So a really big list of concerns with fentanyl patches. It's something to be aware of. We use them. We just have to have client education while we use them. So then we'll talk about some opioids that are a little bit weird. So they're not pure agonists. So we talked about this a little bit earlier in our example. So we've got butorphanol. Butorphanol is a mixed agonist-antagonist. It stimulates the kappa receptor. It's an agonist for kappa receptor, which creates a little bit of sedation, but it also binds with the mu receptor but produces little effect. Okay, so it can connect with kappa receptors, that's fine. Nobody cares too much about that. But the key here is that it binds with mu receptors, which every other or most other opioids that we'll talk about also bind with, but it produces little intrinsic effect on the cell. So it's a kappa agonist, but a mu antagonist. So this means that it can take up some space on the mu receptors and essentially block other mu stimulants, or not, stimulants isn't really the right word, other mu susceptible drugs from working. It's also considered a partial mu agonist and partial mu antagonist because essentially it can be given it can be given, let's say we give hydro, the animal has really profound effects. They are really, dysphoric. They're really all over the place. We can actually give butorphanol to reverse some of those effects in a way, because when we give butorphanol, it's going to cling to the same receptors that the hydromorphone clung to, but it's going to produce no effect on the cell. So it potentially could even, it won't necessarily bump out the hydromorphone, but it will take up the space on the receptors and provide little effect. So that's really important because we can use it to reverse a little bit of the hydromorphone or fentanyl or morphine. But at the same time, let's say we get an animal that came into a clinic painful and the doctors at that clinic treated it with hydromorphone, and then it comes to our clinic and your vet wants to give it butorphanol. It's really important to note that if you're giving it butorphanol, you might actually shorten the effects of the analgesia, because what you're doing is you're taking away the opportunity for hydromorphone to work on those receptors, those mu receptors, by giving butorphanol. So now hydromorphone that used to, would last for 4 to 6 hours, make the animal really great and pain-free. Now you're bumping that with butorphanol, and butorphanol is taking the main effect. And butorphanol is kind of crappy. I'll always call butorphanol crappy because it only lasts like 30 minutes. So it's just important to know that those two are incompatible. You can't use hydromorphone as well as butorphanol to get a combined effect. They work against each other. Buprenorphine is another weird one. It's a partial mu agonist. It binds with mu receptor, creates an effect, but it's much milder effect than other mu agonists. So that's one that, again, if you give it and you've already given hydromorphone, you might actually reduce the amount of opioid effect that you have on that cell. Mostly important for combinations of drugs. So if you have an animal in hospital who's getting hydromorphone, we got to be cautious using buprenorphine and butorphanol. However, buprenorphine and butorphanol can work together. We can switch from using butorphanol IV and immediately go into buprenorphine, and you're not ruling out one for the other. All right, buprenorphine. So it's an opioid. Trade names are Vetergesic. We also get it from the vet pharmacy or from Summit. They compound it in various concentrations. So always, always, always double check the type of buprenorphine and the concentration that you're using. We can give this sub-Q, IM, intravenously, and then also transmucosally. Mode of action, as described previously, it's a partial mu agonist, and it's actually a kappa antagonist. Positive effects. It lasts longer than some other opioids, like butorphanol. So it lasts 6 to 8 hours, so we often give this, up to about 3 times a day, typically, sometimes even more often. It's the least likely to produce negative effects associated with opioids. So we're not going to get major respiratory depression. We're not going to get the vomiting associated with other opioids. It has rapid absorption across mucous membranes, Really great for feral cats because of this, because when they're hissing at you, you can just spray a little bit of buprenorphine in their mouth and it gets absorbed quite rapidly. There is also an option for 3-day buprenorphine injection, which makes client compliance really much higher. And then, of course, going back to that mucous membrane, so the absorption, the transmucosal version, clients really like that one at home. It's much easier to give than a pill. Side effects are the downsides. It's not quite as potent as morphine, and it does have a ceiling effect. So what that means is the amount of buprenorphine can influence the duration of the effect, not its overall effectiveness. So when we give the maximum dose of buprenorphine and we continuously give that high dose of buprenorphine, it doesn't mean that it's going to have a stronger effect on the cell. It just might mean that it lasts longer. So that's the ceiling effect. It will only work so well, okay? And then it's capped. So it will never work as well as hydromorphone in order like to cap the analgesic effects. But the more we give, the higher dose we give, the longer it could last in the patient. And then we have butorphanol, which I always call crappy. It does have properties that make it really beneficial in some circumstances, but not as a primary opioid. So we never ever give butorphanol as the primary analgesic medication. It does not last very long. So trade names for butorphanol are Torbogesic. It's typically 10 mg per mil. Mode of action, it's a partial agonist-antagonist. It can be a weak mu agonist to mu antagonist, plus a strong kappa agonist. So it's a strong kappa agonist. I want you to remember that because it causes profound sedation. So most often, we'll use butorphanol not for its analgesic effects, but for its sedative effects. So we often use butorphanol in a dose of 0.1 to 0.3 mg per kg for sedation for hands-free radiography. That is most often where I'm seeing butorphanol used, or in combination with a sedative or tranquilizer to create neuroleptic analgesia, but not as a primary analgesic. So it can be used to reverse some of the respiratory side effects of full mu agonists. So like I said, you don't typically want to give hydromorphone and butorphanol together to create an analgesic effect, but if you're having too much of an effect of hydromorphone and you don't have naloxone, then you can give some butorphanol and it can actually decrease some of those respiratory effects. It's excellent for sedation, less respiratory depressant effects, so it's really good in older animals as well, and it does have excellent cough suppression. Side effects, not as potent as morphine, has a ceiling effect, so again, it will only work so well. Really short duration of analgesic effect. So it's 30 to 60 minutes in the dog and 90 minutes in the cat. Never recommended to be used as the primary source of analgesia. So this goes hand in hand with surgery. It's something to think about. Right now we're using it typically as a neuroleptic analgesic where we'll combine it with acepromazine and we'll get sort of some pain management and some sedation. But with that pain management, we have to look at something else. So we can't rely on the butorphanol from that neuroleptic analgesic to be the only source of pain management for a surgical patient. That's crazy because after half an hour, goodbye, it's gone. And that animal is quite painful again. And this one we can give sub-Q, IM, and IV. So then we have Tramadol, which is sort of emerging. They're trying to figure out what Tramadol is really good for. They use it in people a lot. They often use Tramacet, which is Tramadol combined with acetaminophen. So Tramadol is kind of weird. It's a centrally acting analgesic plus or minus some opioid receptor activity. So it doesn't work in the same ways that like hydromorphone or butorphanol or even buprenorphine work. It actually works on the central nervous system. And it actually has a ton of different methods of action, to be honest. So it typically is given as an oral tablet for dogs and cats. Compounded tablets or generic tablets, 10, 25, 50, and 100 milligrams are typically the strength. Has different modes of action, so it has a little bit of a mu agonist property to it. It prevents the reuptake of serotonin and norepinephrine, and it also blocks receptors that normally respond to acetylcholine. Also, it stimulates alpha-2 receptors to produce sedation and analgesic. So it is not a straightforward drug, and it's definitely not a straightforward opioid at all. We do consider it essentially an opioid or an opioid derivative or a subtle opioid, so we do tend to consider it as a controlled drug in most clinics because it has some opioid receptor activity. Positive effects, it has some analgesic effects. It has better analgesic metabolism in the cat than in the dog. That's something important to keep in mind. Side effects, the full extent of analgesic effect is not really known, and its uses aren't entirely known. The dog, we know it's not well metabolized. It's not to be given with behavioral modification drugs classified as select serotonin reuptake inhibitors, because it can cause serotonin syndrome. So let's just break that down a little bit more. So side effects with tramadol, we actually don't know how well it works in dogs and cats, especially the dogs. It's generally not well metabolized. So if we're giving tramadol as the primary analgesic in dogs, it might be something to consider that it's not working very well. And again, we have to go back to monitoring for signs of pains. And then secondary, this piece, the contraindications, we do not give this with some certain behavioral modifying drugs that are select serotonin reuptake inhibitors. It's quite a mouthful, because we know that it does block receptors it already prevents the reuptake of serotonin. So in the brain, if we have too much serotonin circulating, we can get this weird disease, this disease process called serotonin syndrome. And that can happen with all sorts of drugs, but tramadol is one of those drugs that we have to watch out for serotonin syndrome with. So that's a bit about tramadol and about the really common drugs that we've used so far that are opioids or analgesics. Less common opioid is meperidine. So this one's not Benadryl, stupid me, Demerol. And we don't see Demerol a lot anymore. So the trade name is Demerol. The generic name is meperidine. It has a fifth of the analgesic properties of it, that should say morphine. So it's a weaker agonist. It's a cardiac depressant. It's shorter acting. For all of these reasons, we don't really see Demerol used in the clinics much anymore. Demerol also has a really high potential for addiction in humans, and it used to be a pretty big street drug. So it's something to think about. A lot of clinics over time have gotten rid of it. There's a lot of addiction with Demerol, and there sadly is a lot of addiction in the veterinary field with Demerol. When we're giving Demerol, if you do see it, just remember that it is a cardiac depressant. That's the key downside to it. So we have to be cautious of the type of patients that we're using it in. And it does come in oral or in injectable form. All right, so let's talk a little bit about the main antagonists that we focus on when we're talking about the use of opioids. So we have an opioid receptor antagonist, and this is naloxone. The trade name is Narcan. They work by competing for spaces in the mu and kappa receptors. It has zero intrinsic effect on the cell. So this means that it connects to the receptor, 100% connection to the receptor. It's that missing puzzle piece. But then it has no effect on the cell. So essentially, this one is going to take up more spaces, similar to what butorphanol does, but butorphanol has a weak effect, so it will produce some opioid effect on those cells. Naloxone actually produces zero effect. So it will in fact reverse the sedation, the analgesic, and the respiratory effects of opioids. Caution with use, it's best in cases of overdose because it does reverse the analgesic effect. We need to make sure that we're supplementing analgesic through another form, but it's most often used in the case of overdose, or if an animal is really dysphoric, so they're really, they're hallucinating like crazy, they're panting, they're screaming, because we've given them maybe too much hydro, too much morphine, then we'll start titrating the dose of naloxone to reduce those until we start to see the effects being reduced. So naloxone is really great, and as you know now, probably we have naloxone kits that are used for overdose of street drugs, where we give naloxone to humans intranasally as a spray to start reducing the effects of opioid overdose. So this is our little chart. Here's our little example of how it works. So let's put it into play. Again, this is our plasma membrane. We've got our little drug receptors that technically sit within the plasma membrane, and then this is the inside of the cell. So our agonist, morphine, binds to mu receptors and has intrinsic activity. So it binds to the receptors, it's a missing puzzle piece, and it has a really high effect on the cell. The vet, they're concerned that the animal is suffering from the effects of a high dose of morphine, has great analgesic properties, but in high doses, the respiratory depression has set in. So they tell you to go ahead and give naloxone. Why? Because naloxone is a mu antagonist. The naloxone will happily bond with those receptors and it's going to have zero effect on the cell, which will take over the effect. So it's like it kicks out the effect from the hydromorphone, and instead it's spreading that no effect, so it like totally nulls the effect of hydromorphone on the cell. All right, so that is a ton. That is a lot that we've gone through. We'll go through some more examples in class, and you'll have a chart to complete to sort of keep things organized a little bit more. When you start utilizing this in class, in surgery, with animals, you'll start to actually get a more of a hands-on approach and a little bit better visuals about how these drugs affect the animals. This is the basics of why they affect the animals in that way. So then lastly, opioids, of course, are controlled drugs. They have a high potential for addiction. So we have to keep a control of them in the clinic. We need to know the drugs that have gone out and the drugs that we have as a balance, and we need to know who they went to. So this is a Purdue University record of controlled substances that have been administered or dispensed. Every clinic has this. We have to have it because of this College of Veterinarians of Ontario. They regulate this. They check this every time they come in to do an inspection of our clinics. So essentially you have the name of the controlled drug, the form, the strength, and the size of the bottle or vial. And then every single time we used a controlled drug, we need to identify the date, patient, /animal, name and address. So we have to have the patient name and the client name. Sorry, this is human. No, it's not. Silly me. We have to have the patient name, the animal name, and of course the client's address and phone number most often, or at least an identifying feature of how we can contact them. Species is debatable. Sometimes we keep species, sometimes we don't. The initials of the person administering or dispensing, so we often have the RVT's initials and the vet's initials. And then we have the amount taken out and then the new balance. Next lecture, we are going to start to talk about tranquilizers and sedatives. Thank you very much.